Yes, sir.
So, good evening, everybody. I'm Dr. Vasan Nagvekar. I'm the Secretary, Clinical Infectious Disease Society in India. It's a great pleasure to be having a joint program, Clinical Infectious Disease Society with Ceylon College of Physicians. And today, this 15th June, we are going to have a 2 hours jam-packed session and looking forward for great talks by Dr. Chandra, Dr. Soman, and then a good panel discussion. So I think we will definitely, this is just a beginning. We will definitely take it at a much higher level and to finally have a sharp meet with our neighboring countries. That is the vision in future. So looking forward for this. And I just want to thank Dr. Nilanka, who has been the key to connect all of us with each other today, this evening. Thanks, Dr. Nilanka, for that. And I hand it over to Dr. George Verghese, who is the President, Clinical Infectious Society, for his presidential address, and followed by Dr. Uppal. Dr. George, all yours.
Thank you, Vasant. Good evening, colleagues and friends. It is my honor and privilege to welcome all of you on behalf of the Clinical Infectious Diseases Society, to this landmark joint meeting with the Ceylon College of Physicians. A special word of welcome to Dr. Uppal and all our Sri Lankan colleagues. Some of us have had the opportunity to interact with the Infectious Diseases Forum in particular of CCP and give online talks and annual conference in the past. The convergence of the minds from CIDS and CCP today is a testament to our shared commitment to advancing medical knowledge, improving patient care, and fostering collaborative efforts in combating infectious diseases. I wish and hope our collaboration will grow from strength to strength. As we delve deeper into the critical and ever-evolving fungal infections, we are privileged to have two eminent speakers with us today, Professor P. Chandrasekhar, fondly called as Dr. Chandra, and Dr. Rajiv Soman. Many of you may know that Dr. Chandra is the Division Chief of Infectious Diseases at Wayne State University and is an authority on fungal infections. He has been my mentor since my fellowship days and has been closely interacting with CIDS, and he is originally from Sri Lanka. Therefore, there's no better person to link both our societies and talk to us about the diagnostic challenges of fungal infections. To complement this, we have Dr. Rajiv Soman, a senior ID physician with a wealth of experience in managing fungal infections and discuss the treatment of mold infections. I congratulate Vasant, Nilanka, and all the organizers for putting together this excellent program. And I look forward to an evening of fruitful discussions and learning. Thank you very much.
Dr. Uppal, your...
Yeah. Ladies and gentlemen, I'm Uppal Disanayaka and I'm the president of Ceylon College of Physicians. And Ceylon College of Physicians has been in existence from 1967, and I'm the 57th president of the college. It gives me great pleasure to provide this opening remark. The honorary treasurer of the College of Physicians. And we have Dr. Amita Ratnapala, a consultant respiratory physician from the National Hospital of Galle. And our panelists are Dr. Vimalsiri Uluwathake, a senior consultant physician and president of Galle Clinical Society, Galle Society of Medicine, and the convener of the Infectious Disease Forum of the CCP. And Dr. Nilanka Pereira, who's a senior lecturer in medicine of the University of Jayawardhanapura and a consultant physician, and is Secretary of the Infectious Diseases Forum. And lastly, Dr. Namal Jayawardhan, a consultant mycologist from Apeksha Hospital, which is the tertiary care referral center for cancers in Sri Lanka. And we have very experienced clinicians and esteemed academics from our side, and we are seeing equally powerful side from India, and we look forward to a very successful CME program. Over to you, the panelists and the moderators.
Thank you so much, Dr. Upal. I hand it over to Dr. Madhumita, who is a senior consultant infectious diseases at MGM Healthcare, Chennai, and she will be taking on the proceedings for the whole program, and Dr. Suranga will join later on for the panel discussion. All over to you, Dr. Madhumita.
Thank you, Dr. Vasant. Ladies and gentlemen, good evening, good afternoon, and good morning to Dr. Chandra and the others joining from the West. Welcome to this joint CME between the two neighboring countries. It is a pleasure to be here with you today, bridging our borders with shared knowledge and collective expertise. Infections, as we all know, recognize no border, and thanks to COVID-19, we have been starkly reminded of this reality. The pandemic taught us many lessons, and one of the most significant is being the importance of global collaboration in the field of healthcare. It showed us that microbes don't need passport, and neither should our efforts to combat them. This joint CME is a testament to the power of working together. The pandemic, while challenging, has brought about a silver lining by making such collaborative CME sessions more accessible. Thanks to the wonders of technology and platforms like Zoom, we can now effortlessly share insights, experience, and knowledge across countries without the constraints of physical distance. So let's embrace this opportunity to learn from one another, to share our successes and challenges, and to strengthen our collective ability to fight infections and improve patient care. Together, we are stronger, and together we can achieve so much more. Thank you for being here, and let's take the session both informative and enjoyable. I thank the CIDS President, George M. Verkes, and his team for giving me this opportunity today. Before I introduce my first speaker, may I request all the participants to keep their audio on mute and type their questions and queries in the chat box, and we would take them at the end of the session. Our first speaker for this evening is Dr. P.H. Chandra. It's my distinct honor to introduce him. Originally from Sri Lanka, Dr. Chandrasekhar pursued his medical education in India and now is a professor and head at the department. He's also the chief of the infectious disease department there. He's been in India and has been very supportive of inception and development of CIDS India over the years. He has trained and supported many ID doctors through this program in the US. His journey in medicine has been marked as a relentless pursuit of excellence, a deep commitment to patient care, and active involvement in research and education. His efforts not only enhance patient outcome, but also mentor the next generation of healthcare professionals. We are privileged to have Dr. Chandrasekhar with us today. His valuable insights and vast experience will undoubtedly enrich our session. Please joining me in welcoming diagnostic challenges in invasive fungal infections. Over to you, sir.
Thank you. Can you hear me?
Yes.
Can you guys hear me?
Yes, sir. Very well.
Very good. Okay. Good evening, everyone. Thanks, Madhumita, for the lovely introduction. Yes, I'm delighted to be here. Thanks to Vasant for the kind invitation. This is right after my heart to be involved with the Sri Lankan activities. This is a long-term dream of mine to see infectious diseases specialty evolve in Sri Lanka, and whatever I can do, I'll be more than happy to be involved in the development of this specialty there. I attended St. Benedict's College in Kotahena, Colombo for 12 years. These were my formative years. I remember them very, very, very fondly. And in the late 60s, I moved to India to pursue medical education at Christian Medical College, Vellore. And from there on, I moved to the United States. So that's a story for another time. Let's move on to my topic. If Vasant would be kind enough to project my first slide. The topic that I was asked to talk about is diagnosis of invasive fungal infections. Okay, if it can go on the slide mode, presentation mode.
Can you see the slides?
Yeah, I can see the slides, but it's not in presentation mode. Can you?
It's in. It is.
Is it for you?
No, it is not. Vasant, the right lower
It is in
corner, you have the big screen picture. Just click on that.
No?
I'll just stop share and do it again, sir.
No. Vasant, that full screen picture.
Yeah, I did do that. 1 minute.
Yeah,
Okay.
there it is.
Perfect. Thank you. So the topic is diagnostic challenges in invasive fungal infections. Obviously, as the topic implies, there are lots of problems in trying to get a diagnosis of fungal diseases. So let's move on. So you can see here, when we speak of fungal infections, which fungi are we talking about? So the fungi, which are of common, which are a common problem in humans, are listed here by the WHO. You can see the priority pathogens classified into the top 3 groups, the critical group, high group, and the medium group. So in the critical group, this particular organization feels Cryptococcus, Candida auris, Aspergillus fumigatus, and Candida albicans being the ones of highest priority. And then next in order is Candida glabrata, Histo, Eumycetoma pathogens, Mucorales, Fusarium, and 2 other species of Candida. And in the final, we have Scedosporium, Lomentospora, Cocci, Candida krusei, Cryptogattii, Penicillium or Talaromyces, Pneumocystis, so a variety of others. So this in general, for those of us clinicians, we've encountered most of these organisms in our population. So this is how the WHO views the clinically important fungal pathogens today. So how do we diagnose when these pathogens enter humans and cause havoc? Next slide, please. So here on the left-hand side, I've just listed the most commonly encountered pathogens from that list. Candida, Aspergillus, Cryptococcus, Mucor, Pneumocystis, endemic fungi like Histo, Blasto, and Cocci, Fusarium, and Scedosporium. And all of these infections are rapidly increasing in number over the last 20, 30 years. As you can see here on this slide, it's a slide from 2006 to 2015, the incidence of invasive fungal disease per 100,000 patients. So the top line indicates all invasive fungal infection. As you can see, somewhere around 30 to 35 per 100,000 patients, all invasive fungal infections are being seen. Among these, the next line indicates Candida. Candida is the primary fungal pathogen. You can see it somewhere to the tune of 20. The main message is in the last 10 years, 2012, 2013 onwards, there has been a steady, slow rise in the frequency of invasive fungal infections, namely Candida, Aspergillus, endemic fungi, and a variety of other organisms. Next slide. Why? Why do we have this rise in fungal diseases? To the extent the mortality is increasing as well. There are multiple reasons. The three most common ones I picked are the hosts. These patients frequently with fungal diseases, their immune system is compromised. And therefore, the epidemiology is so complex in these patients, posing huge management challenges. Diagnostic difficulties in making an early diagnosis, and the drugs are not optimal. The efficacy is somewhat subpar, plus the toxicities we have to deal with are not minimal. So for these particular reasons and a variety of other reasons, invasive fungal disease treatment poses huge management challenges. Next slide. Who do we see these invasive fungal diseases in? The underlying hosts are listed on this slide. As you can see, invasive Candida, invasive Aspergillus, Mucor, and Cryptococcus are primarily seen in patients with hematologic malignancies, patients undergoing hematopoietic stem cell transplant, solid organ transplant, patients with solid cancers, HIV patients, surgical, particularly surgical ICU patients, and medical patients, particularly ICU patients. So this is nothing new. Most of us are very familiar with that. Today, the most commonly affected patients with invasive fungal disease are compromised hosts, and they are the ones listed on the slide. Next slide. And they pose huge management challenges. What are they? One, the mortality still remains very, very high. With invasive Candida, from phase 3 studies, still we encounter 10 to 18% mortality despite the use of azoles and echinocandins. For invasive Aspergillus, the mortality remains around 20 to 25% despite the use of azoles and avoiding polyenes like amphotericin. In the real world, outside of these studies, probably the mortality is even higher to the tune of 30 to 40%. The drugs available, as I mentioned, are limited. Clinical trials are challenging because they are very hard to recruit patients into these studies. The numbers are very, very low. As you can see, the recruitment rate in many of these trials per site per year is 1.9 patients for Candida and 1.5 patients for Aspergillus. This is very, very poor enrollment. So these are clinical trials to conduct, usually involves several thousands of dollars, which most countries can't afford. And the pathogens are frequently very, very resistant. Today, we see Candida auris reported in multiple countries with significant mortality. Azole-resistant Aspergillus is increasing in number, particularly with COVID-19. And many of the fungi are inherently resistant to the currently available drugs. All these pose enormous management challenges in the management of invasive fungal diseases. Next slide. And the one area I'm going to be concentrating today is the diagnostic difficulties. Why is the diagnosis so difficult to make in invasive fungal disease? Because they're usually in sick people. When the patient is sick, the platelet count may be low. I can't perform invasive procedures to obtain a biopsy. So that makes it even harder. And when patients are sick, most likely their immune system is compromised. And many of these fungal diseases have no unique signs or symptoms. They're very, very non-specific. Patients may be febrile, malaise, may have some diarrhea, very, very non-specific symptoms. Serological response may be compromised because of their immune system. Histology, many of these organisms look very, very similar. Aspergillus, for example, there are 25 other organisms that look like Aspergillus under the microscope. So diagnosis becomes very difficult if you depend on histology alone. fungi, we all know very well, don't grow very easily in the lab. They are very slow growers. Many of the tissues fail to grow the fungus, even if there are live fungi within the specimen. Therefore, the sensitivity from a culture becomes low. So the bottom line is, today, the conventional diagnostic methods that we have, such as histology, serology, are very, very suboptimal. Next slide. Let's look at individual pathogens. Candida, as we know, these are the infections that we see commonly with Candida. Candidemia, systemic candidiasis, and for the mucosal diseases, could be oral or vaginal candidiasis, or cutaneous or nail candidiasis. Next slide. Now, these are the risk factors. Most of us are very familiar for patients to get candidal disease. The host factors and a variety of different interventions that are performed, which will increase the risk for invasive candida in such patients. Most of us are very familiar with these risk factors. Next slide. This is a patient with typical disseminated candidiasis. Next slide. Okay. How do we make, can I go to the next slide, please? Okay. Okay, you can see here one of the tests that we use in making a diagnosis of candidal disease is beta-D-glucan assay. Here, the beta-D-glucan is a cell wall constituent of candida. These are the slide here that shows, okay, let's just stay on one slide, beta-D-glucan in serum. And the most important point about this particular assay, if the assay is negative, it has a very good predictive value to say that the patient is less likely to have candidal disease. The sensitivity is not that great, but the specificity is very high. And the beta-D-glucan is a common constituent for many, many of the fungi, such as Candida, Aspergillus, and others. And therefore, it's a pan-fungal test. Crypto and Mucorales contain alpha-D-glucan, and therefore the beta-D-glucan test would be negative in such patients. False positives may occur in the presence of filters, gauze, sponges, IVIG, and albumin. So one needs to be cautious, particularly in the setting of dialysis or in the ICU setting. Most of the data are obtained in highly compromised patients. So in the regular run-of-the-mill patients, the data are quite limited, so you may not be readily able to use this test outside of the immunocompromised population. So the bottom line, in the United States today, this test is widely available, but many, many times the hospitals have to send out, and there is a turnaround time problem, and therefore that hampers the immediate care of our patients. This is the problem with beta-D-glucan. Next slide. Okay, so these are the various tests that we can use for the diagnosis of Candida. Blood cultures, as you know, the positivity rate in patients who have invasive candidiasis is somewhere in the range of 30 to 40%. So nearly 2/3 of the patients may have a negative blood culture in the presence of systemic candidiasis. Beta-D-glucan, we talked about, excellent negative predictive value. So we need to obtain biopsies in these patients. And as I mentioned, in the compromised setting, biopsy may not be a realistic thing. What are the newer methods for diagnosis? MALDI-TOF and T2 magnetic resonance assay. Many of you, I know in India, the MALDI-TOF is available in many of the larger institutions for prompt diagnosis and identification of the fungi. So this has become very widespread, and it's becoming rapidly available in many, many countries. The magnetic resonance assay is more reserved. Next slide. This is a qualitative molecular diagnostic method, and these are the movement of the water molecules in relation to the magnetic fields in the specimen and looking for these organisms, even if they are present in minute quantities. There is a large machine that operates these, and there is an investment cost involved in acquiring these machines, and it detects a variety of different organisms, both bacteria as well as fungi. Among the fungi, as you can see, the 5 species of Candida are able to be detected by this test, and it's extremely sensitive test. However, because of the cost involved, it has not become very popular. My guess is that in the resource-limited countries, this may become a big problem and therefore may not be widely available. In the even our center, we do not have this because of the cost, so we would have to send out if we need this assay. And the problem will be low prevalence setting. Sometimes you'll have negatives and it becomes difficult to exclude the diagnosis. And if the patient is not candidemic, and if the organism happens to be buried in the systemic tissues, the diagnosis may be negative. So there are some problems with this magnetic resonance assay. Next slide. Cryptococcus. Cryptococcus, as you know, is acquired by inhalation, can produce the common infections that are listed there. And the at-risk patients, most of us know, these are HIV-infected patients or patients undergoing steroid therapy or underlying disease such as lymphoma. What are the diagnostic tests today? The main diagnostic test is culture and antigen-based. And the antigen can be performed in both in the blood as well as in the CSF, as frequently meningitis is encountered. So today, our main 2 tests that we depend on for the diagnosis of cryptococcal disease are cryptococcal antigen in the serum or in the cerebrospinal fluid and culture. Okay, next slide. Aspergillus. Aspergillus is a common mold that we see, particularly in immunocompromised patients. A respiratory route is the usual point of entry, and therefore you would see pneumonias, sinusitis, from where the organism can disseminate hematogenously to other structures, such as the CNS and the skin. This is the usual. How do I make a diagnosis of invasive aspergillosis? Next slide. So today we have 2 or 3 methods. 1, radiology. Radiology, we depend on high-resolution CAT scans to make a diagnosis of invasive aspergillus. As for blood test, we depend on serum galactomannan and bronchoalveolar lavage galactomannan. We could also do the same antigen detection and other specimens like the CSF or pleural fluid. And the third test is the PCR. So these are the common tests that are currently used. Besides culture and histopathology, we depend on radiology, and there are some typical findings depending on the clinical situation that are well described. Galactomannan is relatively recent in the last decade or so, and it's very specific in the setting of appropriate host. Next slide. Mucor. In Mucor, next slide, it's tougher. It's very difficult. Today, we depend upon culture and histopathology. We do not have any other rapid means of detecting Mucor. As you can see on this slide, who are the patients who might come down with Mucor are listed on the left-hand side, and the patient-related factors and the environmental factors are listed on the right-hand side. As far as the diagnosis, as I mentioned, we have not made a whole lot of progress in day-to-day clinical practice for enhancing the diagnosis of Mucor. Next slide. Pneumocystis. Pneumocystis, as you know, presents most commonly as pneumonia with diffuse bilateral interstitial infiltrates on chest X-ray in patients such as those with advanced HIV or transplant recipients or patients who are receiving immunosuppressive therapies for a variety of different reasons. How do I make a diagnosis of pneumocystis? You can use specific stains either in the sputum or in the BAL fluid or in the lung tissue. We do not have culture at this time to make a quick diagnosis of pneumocystis. PCR is of increasing use. In fact, this last week's Clinical Infectious Disease has a lovely paper on the pneumocystis PCR for diagnosis of pneumocystosis. And essentially, it is available in multiple centers. It is not standardized. If negative PCR would indicate absence of the disease, again, its negative predictive value from appropriate specimens would be useful. A positive PCR will be difficult for us to distinguish between colonization and infection. Quantitative PCR may help, but it requires standardization and validation studies. That's the problem we have with PCR today with pneumocystis. Next slide. So, in summary, you can see Candida, we have beta-D-glucan, MALDI-TOF, and magnetic resonance assay for today's diagnosis, besides the standard tests that are culture and tissue morphology. For crypto, we rely heavily on cryptococcal antigen. For Aspergillus, it's the galactomannan antigen. We have progressed quite a lot in the last 2 decades, and PCR is rapidly becoming an important tool. However, there could be false positives not widely standardized today for aspergillosis. Next slide. With further summary, with Mucor, there are no rapid antigen or PCR tests that are widely available and accepted. We rely on morphology and culture. Rapid tests are costly and are not available at this time. For pneumocystis, beta-D-glucan can be useful. I hadn't mentioned that earlier. Beta-D-glucan would be, if present, they are usually present in large quantity, and a negative beta-D-glucan is a good method to eliminate the likelihood of pneumocystosis. There is no culture method available. Immunofluorescence in the BAL fluid can be performed. Again, tissue morphology, the lung tissue, and finally PCR I commented on. As for histo, blasto, and cocci, we depend upon antigen, both in the urine and serum. Antibody testing in immunocompetent hosts would be useful, and of course, tissue morphology if tissue is obtainable. Next slide. So the tests of promise, the PCR, identifying mutations associated with resistance, and non-Aspergillus molds, PCR can be used today. 2, high-resolution MELT. Again, this is depending on the melting curves of organisms while doing the PCR testing. It's rapid, not widely available. And finally, metagenomic next-gen sequencing. And these are 2 of them. I would like to concentrate on the PCR for Aspergillus and metagenomic next-gen sequencing. Next slide. Next slide, please. Okay, PCR, you can see here, we published a paper not so long ago, PCR reaction in the diagnosis of invasive aspergillosis. It's useful for early diagnosis. However, you look at the 3rd sentence, well accepted standardized method for DNA extraction is to be adopted for all commercial assays, and conclusive validation data are awaited. So it's not all the way there. However, PCR can become useful if validated. Next slide. So based on what we have available, we created this appropriate scenarios where we could use PCR as a tool in diagnosing Aspergillus. For example, if you look at scenario 1, where we may have a high-risk patient with concomitant clinical and radiological findings who is not on anti-Aspergillus prophylaxis, obtaining 2 Aspergillus PCR or a combination of PCR with galactomannan can be used to diagnose Aspergillus. Scenario 2, similar scenario with the patient on anti-mold prophylaxis. Here, it would be useful to eliminate the likelihood of invasive Aspergillus based on a single negative plasma Aspergillus PCR. In the high-risk neutropenic patient with only fever, without respiratory or radiological findings, a single negative PCR may help rule out a diagnosis of invasive Aspergillus. So we could use some of these bedside quick methods for how to use serum Aspergillus PCR for a diagnosis of invasive aspergillosis. Next slide. Okay, let's move on to metagenomic next-gen sequencing. This is something fancy. This is available. It's expensive in the United States. There are few companies that are doing this. Carius is one of the first one. And the next few slides are from them. It's obtaining a liquid biopsy for infectious diseases straight from a sample of blood. So if you suspect a patient to have an infection in the bloodstream, obtaining a sample of blood, and within a day, the company can provide you an answer for at least 1,000 plus detectable pathogens. So essentially, the test is supposed to look for microbial cell-free DNA. Okay, so this is even looking for a needle in a haystack. So this microbial cell-free DNA, you can see, can be useful for the detection of bacteria, viruses, fungi, as well as parasites, to as low as 0.001% in a 5 ml blood. So this is extraordinarily sensitive. They're essentially looking for non-mammalian DNA in the bloodstream of the suspected individual. We do this, we send it to a company. The turnaround time is about 2 or 3 days, and they charge us almost $800 to $1,000. So it's extraordinarily expensive at this time, but clinical utility is there when we are struggling with some patients with no clear diagnosis. Next slide. Reports are typically available 1 day after the specimen is received. The specimen is processed, sequencing is done, and once the sequencing is done, it is added that the company has with at least 1,000 plus pathogens. Whichever matches, finally the report comes out, both qualitative as well as quantitative. So it's become, in our practice, we've done it about 30, 40 times. It has been somewhat useful. I wouldn't say it's wonderful, but it's of limited, somewhat useful to us. But again, as I mentioned, it's very expensive. And as you can see, the useful clinical situations include pneumonia, fungal diseases, FUOs, vertebral osteo, focal abscesses, endocarditis, and zoonosis. Next slide. And you can see this slide shows the comparison of this metagenomic next-gen sequencing test, Carius test, comparison to culture, antigen test, serology, PCR, and other next-gen sequencing testing. Overall, as I said, it can detect a variety of different organisms. However, it only detects DNA, RNA pathogens, RNA viruses like COVID. We cannot use this test. Finally, what about PET-CT? Many of us use PET-CT in a limited way. In the US, getting the insurance to approve PET-CT is a challenge. However, if PET-CT is available and doable in the appropriate situations, as you all know, it provides anatomical data plus the functional data with the glucose uptake. And it's very useful both for diagnosis and assessment during therapy. There is a lot of publications today for the use of, please go back to that slide, for the use of PET-CT in the diagnosis of invasive fungal disease. The limitation, of course, is if the FDG uptake is there and the PET-CT is positive, that doesn't confirm because it's fairly non-specific. So to overcome this limitation, there are today special traces being added to the PET-CT, and these specific traces may be useful in overcoming that limitation, and it can be specific for specific fungal pathogens. And those are under study at this time. So we use FDG PET-CT on a very limited scale in diagnosing invasive fungal disease or to assess progress of infection. Next slide. So to summarize, the state of the art today, we have limited tools to diagnose invasive fungal disease. We still rely on clinical factors, radiological factors, and of course, who the patient is, how immunocompromised the patient might be. So we give weight of evidence for each of these factors, and putting them together, we have algorithms to say how likely is the disease. Is it possible, probable, or definite? So what is needed? All these new diagnostic tools I just talked about, we need implementation studies and validation studies. And all those are going on at this time. And importantly, even when these studies tell us the presence of an organism, we need to be able to distinguish, are we talking about a colonization or are we talking about true infection? That, again, is up to the clinician at this time. So quantitative PCR may be helpful. Again, one needs validation to assess the significance of the quantity in terms of true infection. Again, to make these tests accessible to limited resource countries all around, we need centralized labs so there would be ready access to the new diagnostics. Next slide. So in summary, invasive fungal disease infections occur annually around the globe. Diagnosis, as I mentioned, customary diagnostic methods include culture, serology, and pathology, or microbiome and pathology. Those are the three that we have used for the past several decades. New tests are coming into place, but at the present time, we need low cost, easy to use, highly sensitive, specific molecular assays. And these assays should be able to tell us the difference between colonization versus infection in clinical specimens. So we have a long way to go, but we've made a lot of progress in the last few years with the new tools that are rapidly coming into clinical use. I think I'll stop at this point. Thank you.
Thank you so much for your valuable insights on a difficult topic and a difficult diagnosis of fungal infection. I have one question for you in the chat box, sir. So probably we'll take that question. Dr. Jyotsna wants to know, once positive, can we use beta-D-glucan and galactomannan for prognosis, and how often should we repeat the test? Are these tests useful in neonates and extreme preterms?
The first question is, how often should I use beta-D-glucan and serum galactomannan? Yes, the answer is yes to your question. We can use beta-D-glucan quantitation and see in which direction it's going. It can be useful for prognostic purposes. And there are lots of studies for both beta-D-glucan as well as serum galactomannan. If they are positive, if the serum galactomannan, let's say, is 4.5, I would do it on a weekly basis to see how rapidly the decline is being seen. Initially, with therapy, the serum beta-D-glucan will rise. And therefore, one should not make the assumption, oh, the treatment is wrong, I have to switch therapy. No, the rise is expected before the fall begins. So one has to be cautious in interpreting it. I think once a week test should be adequate at this time. Now, what was the second part of the pediatric cases? In general, in pediatric cases, these are not very well studied. The data are quite limited. So I would be hesitant to apply this in the pediatric setting.
Thank you, sir. We have two more. I think we'll just take up this. Can serum galactomannan be positive in chronic pulmonary aspergillosis? Do we need to verify with histology to prove tissue invasion?
Tissue invasion proof is always ideal if you can get to the tissue. The issue is the getting the tissue. That's the problem. That's the challenge. And because these patients are sick, these patients are thrombocytopenic, obtaining a lung biopsy is a challenge. If you can get tissue, that would be ideal. In the absence of tissue, serum beta-D-glucan can be useful, and one has to be careful in the interpretation. And I would rely on serum beta-D-glucan and gradual numbers to see in which direction the number is going. Did I answer the question? I'm sorry.
The question was, can serum galactomannan be positive in chronic pulmonary aspergillosis?
Yeah, usually the study is in invasive acute aspergillosis. It is not in the setting of chronic aspergillosis. The beta-D-glucan simply represents the beta-D-glucan from the actively growing tips of the hyphal organism. So if the organism is not actively replicating, as it might be in a chronic aspergillus setting, you may not be useful. The test may not be reliably used because it represents active replication at the growing tips of the hyphal organism, which may not be the case in chronic aspergillosis.
And my last question is, point of care testing are increasingly recommended. How would you see lateral flow assay for aspergillus versus galactomannan?
Yeah, we do not have lateral flow assays here at our medical center, but there is quite a bit of literature about the lateral flow assay. If they are widely available, and once again, if they are standardized and validated, I think that would be pretty useful. Lateral flow assay would be a point of care test. It'll be easy to do, easy to interpret, and the turnaround time will be rapid. However, today we do not have widely approved lateral flow assays for clinical use. Serum beta-D-glucan is a problem. It requires a laboratory to perform the test. The turnaround time is usually a longer period, so it's inconvenient for immediate patient care.
Thank you so much, sir. With the interest of time, I think I'll take the rest of the questions probably during the panel discussion or at the end of the session. Thank you for joining us early this morning. And we move on to our next speaker for this evening, Dr. Rajiv Soman, who is an infectious disease physician from Jupiter Hospital, Pune, and Dinanath Mangeshkar Hospital, Pune. He's also a visiting consultant at PD Hinduja National Hospital, Mumbai. He was awarded Fellowship of the Infectious Disease Society of America recently. His expertise spans a wide range of infectious conditions, but fungal infections are his favorite. He is a co-chairman for the Fungal Infectious Study Forum and also the executive and founder member, Clinical Infectious Disease Society. Beyond his clinical practice, Dr. Soman has been an influential figure in medical education and research. He's the editor-in-chief of the Journal of Clinical Infectious Disease Society. He's the author of Casebook of Infectious Diseases, Casebook of Invasive Fungal Infections, and Casebook of HIV Medicine. He's the editor of Casebook of COVID-19. We look forward to the valuable perspective on difficult to treat mold infections. Over to you, sir.
Hi, everyone. Can I share my screen now?
Yes, sir.
Okay.
So it's visible. Could you just put it on slideshow?
I think I lost the connection. Am I audible and is my screen seen?
You're audible, sir, but your screen, is not visible. Yes.
Is this seen now and
Yes,
am
sir.
I audible?
Yes, sir. Yes, sir.
Yeah. Okay. Okay. So as Dr. Chandra said, the features of mold infections as other fungal infections, they really overlap with bacterial infections, other infections, as well as with certain non-infectious entities. So it's not something, some signs are pathognomonic, although they might definitely raise suspicion. And also we need to distinguish invasion from colonization or sometimes even contamination. Even if we have these biomarkers, and Chandra told us that it's not always easy, it's a very nuanced interpretation of the biomarker aided diagnosis. And when it comes to molds, you also need an ID to the genus species levels. You need antifungal susceptibility testing. But finally, even if you do that, what is the real relevance of the MIC that you obtain? Because we do not have actually clinical breakpoints. So what you only have are epidemiological cutoffs or ECVs. And therefore, there is a little bit of a gap between what you find in the laboratory and what might be happening in the patient. TDM or therapeutic drug monitoring is a very important feature, and that is very essential for the proper use of azole drugs in treating invasive mold infections. And finally, we should know what are the PK/PD indices which are desired and whether we are somewhere close to achieving those PK/PD indices. Even if you do all these things, remember that the outcome is dependent on a number of other factors and not just related to the mold or to the drug, but also the ancillary management which we can offer to the patient. And finally, on the host, including the host immune status and many other factors. I've organized my talk around two cases which will tell us what are the difficulties and what are the ways we should approach these problems. So beginning the first case, this is a 37-year-old lady. She presented in June 2023. There was a background of CKD and IgA nephropathy. And 6 months earlier in December 22, she had received a kidney from her father. and she had received basiliximab as well as methylprednisolone very soon after the transplant. Now she was on TMP SMX or Bactrim SS single strength on alternate days and was not on INH prophylaxis. She had mild cough for 2 months, but there wasn't any fever, hemoptysis, or weight loss. Her count, white cell count, was just about 10,000. Creatinine was 3.5, and her tacrolimus level was found to be 2 times more than the desired level. So for her cough, she was investigated, and this was found on a HRCT of the chest. So you could see that there is a large, thick-walled cavity. You could call it as a nodular cavitation in the right lung. And therefore, how would we approach this? What would be the differential diagnosis in this particular patient? So remember, this patient had received a fair amount of immunosuppression with these drugs. The tacrolimus level was high. The patient was on TMP-SMX prophylaxis, but it was probably inadequate. This was a subacute process. There was no hemoptysis, there was no fever, leukocytosis, or diabetes, and this was a nodular cavitation. Remember that all these features need to be considered when we construct a differential diagnosis. So if you look at these, what comes to the top of our mind is nocardia, aspergillus, and mucorales. We might also think about cryptococcus. Generally, the imaging features are somewhat different. And about TB, both crypto as well as TB come a little bit later in the course of after transplantation. And maybe the radiological appearance is not so much in its favor. A non-infectious condition such as post-transplant lymphoproliferative disorder also may have to be considered. Generally, that does not cavitate in the lungs. Her sputum, her BAL was negative. And under compulsion to start something, and anybody in practice will know that there will be so many people who will want you to start something. So meropenem and linezolid were started, keeping in mind maybe that this is nocardia or something like that. However, what had happened is a CT image had been missed during the initial consultation. And when we reviewed the entire scan on the monitor, we found this particular lesion, as you can see here. And now, does it change the differential diagnosis? So certainly this shows a lesion with a shaggy necrotic cavitation as well as invasion of the diaphragm and the liver parenchyma. So now this helps us in the differential diagnosis to attune it further. So now it changes to a pathogen that does not respect tissue planes. So it has invaded from the lung across the diaphragm into the liver parenchyma, and therefore that overrides all other considerations. Two important organisms come to mind, actinomycosis and of course mucormycosis. Now, actinomycosis is a little different type of disease, not really expected in this particular patient, and therefore mucor now becomes the leading possibility. So a CT-guided biopsy of this was planned and it was actually done. But I'll remind you that CT-guided biopsy sensitivity of that biopsy is only about 50 to 70%. It is quite possible that a peripheral portion of the lesion is completely necrotic, and then you may not even see the fungus. Fortunately, in this particular patient, you can see the wide aseptate right angle, almost right angle branching fungus, which is highly suggestive of mucormycosis. Now, on inquiry, the patient had cleaned her unused rural home and stayed there for 1 month before the symptoms started. Her creatinine was 3.5. And so the question next in the front of the clinician is what should be chosen for treatment? Would it be isavuconazole alone? Would it be liposomal amphotericin B? Or would it be a combination of these two or something else? None of the above. So one might think of using isavuconazole alone, and that's on the basis of a non-inferiority which has been shown in the vital and secure studies as compared to amphotericin B. And it does have a good penetration into the lung and the liver. What about liposomal amphotericin B? Yes, that has been the traditional drug of choice for treatment of invasive mucormycosis. And here the liver as well as the lung is involved. So let's look at the kinetics of the drug. So you have an excellent penetration in the liver and spleen, as well as kidney and lung. So it might be used for this particular reason. And the nephrotoxicity is something which we may have to keep in mind in this particular patient, but it was thought that this is mainly because of the high level of tacrolimus and is expected to resolve when we use this. What about combination therapy? Now, this is a very uncertain area, and no conclusive benefit of a combination has been found, although it is used frequently. Now, remember here that if you are going to use a combination, it should show not just non-inferiority as is done in many trials, but it should show superiority. You can't use one more drug and just settle for non-inferiority. Okay, so that would really need a very large trial, and no such trial is there. So it's interesting to see this systematic review of literature from almost 22 years. And if you look at this particular review, which was published in this year, you find that when they used, the least mortality was seen when amphotericin B plus azole was used, and amphotericin B followed by azole came the close second. Now, this obviously is not a RCT, it is just a systematic review of the literature. And therefore, you'll have to take it exactly what it really means. So in my mind, the role of isavuconazole in this situation may be that of a supporting drug, especially if you are considering that this patient may need interruption of amphotericin B or even termination for that matter, especially because she is a renal transplant recipient. You might also think of other antifungal agents such as posaconazole. So none of the above might mean posaconazole. It does have an excellent penetration in the lung. There's not much data in the liver. And it is a little bit more, all posaconazole has not been used much in therapy. It has been, as this MOVE-ON study is available. We did use IV posaconazole to start treatment in some patients with mucormycosis, and we really found that when you use that, you have a good therapeutic level within 48 hours of using IV posaconazole. Needless to say, this patient needed surgery. Okay, so this lobectomy specimen was done. We showed that there is this calcoflow stain, showed that there is some invasion of the liver. The LPCB mount of that culture showed that these are broad aseptate filaments with golden brown zygospores and what are called as unequal suspensor cells. So what do we think is this fungus? And what do we know about it? Is it less virulent, less resistant? Is it less virulent but more resistant? Is it common worldwide but uncommon in India? Or what? So it turns out that these are morphological features of what is called as Rhizopus homothalicus. It is virulent as well as less resistant. And there is this paper from Arunalok Chakravarti's group, which has, in this paper, they have listed many cases of this particular fungus. It's mainly reported from India, and that helped us to stop the liposomal amphotericin B and continue isavuconazole alone. And we thought this seems to be a little less virulent, less resistant fungus, so problem is solved, except that it was not. There was clinical radiological worsening, and there was further lung and liver resection was done. But despite all that, the stapled margins did show mucorales. So there is a problem here. So if you look at the global guideline, and I happen to be one of the authors in this guideline, for the diagnosis and management for mucormycosis, it's an initiative of the ECMM along with ESHAM. So if you look at this surgical debridement with clean margins, this clean margins is something which is very, very important. So you really need to go, the surgeon needs to go beyond the disease. And often we must remember here that the clinical findings actually lag behind the disease process. So the disease has already gone further than what you would estimate. So surgical debridement with clean margins is something very important. Along with that, we use these drugs. The drug of choice, of course, is liposomal amphotericin B, but you could use maybe isavuconazole or even posaconazole if there is pre-existing renal compromise, as in this patient. Now, if you get a good response to treatment, that is, it's stable disease, or there is a partial response, there is an option of not continuing amphotericin B but changing to isavuconazole or posaconazole. On the other hand, if you have progressive disease, again there is of switching to isavuconazole or a toxic drug. You can switch over to one of the new azoles. On the other hand, there are certain mucorales species which are less susceptible to amphotericin B. Now, here we did not encounter one, but we must remember that there are some which are less susceptible. For example, there is Cunningham-Miller. So in these situations, if there is progressive disease, there is this option of switching to a new azole. Now, in this particular patient, the outcome was not good. There was secondary bacterial infection. There was leakage from the liver because the liver resection had to be done in a non-anatomical fashion. There was, as you can see here, pleuropericardial invasion, which occurred. And although immunosuppression was minimized, infection continued to gallop and the patient succumbed to the illness. So what messages do we get from this case? We should carefully review all the radiological data. And as this case showed, really, that missing even a single image can really compromise your differential diagnosis. Mucormycosis can sometimes be a subacute illness. Note that this patient had a cough which was going on for 2 months before she presented. Symptoms may be deceptively mild, but the clinical findings often lag behind the disease process. Treatment can be fine-tuned based on the species. In this case, we had Rhizopus homothalicus. Penetration to the site of infection, such as the liver mainly, and also the lungs. What might be anticipated toxicity? What might be interruptions in the treatment? Now, immunosuppression may, especially in a kidney transplant patient, may have to be withdrawn. We may sometimes have to let go of the kidney in order to save the patient's life if you're dealing with a life-threatening infection. And surgical debridement should be timely. It should be done repeatedly and be as complete as possible.
I'm really sorry. I think we lost Dr. Rajiv Soman in between.
Sorry, my connection is unstable, but I think it has come back.
Yes, sir.
Am I audible?
Yes, sir.
And my screen? Or
Not
seen?
visible, sir.
Not visible? Okay.
Yes, visible.
It's seen now? Okay.
Yes, sir.
Okay, so she had severe headache and that was thought to be tuberculomas, and the patient was started on anti-TB treatment, including rifampicin. So she presented to us 7 days later when I was at Hinduja Hospital with sudden blindness. Now, the history revealed that the headache which this patient was having had been of sudden onset, and a diffusion weighted image showed an infarct pattern. On ophthalmoscopy, a string of pearls appearance and a necrotic retina was seen, and therefore this patient was suspected to have aspergillus endocarditis with emboli. Note that usually fungal endocarditis shows large vegetations, and therefore sometimes the patients, the cardiologist might mistake it as a myxoma. So vitrectomy of the left eye was done, voriconazole was started, and anti-TB treatment was withdrawn. Now, what is the drug of choice? Voriconazole is the drug of choice. It is sidal for aspergillus. It has good ocular and CNS penetration, and there has been a lot of clinical experience. But remember here that the patient was unfortunately also on rifampin, and rifampin reduces the level of voriconazole by 95%. Now, why is voriconazole considered the drug of choice? It's on this pivotal trial called as the Herbeck trial, and that showed 57 versus 31% response rates. But there are some issues with the trial because a toxic comparator was used, amphotericin B deoxycholate instead of liposomal was used, leaving some uncertainty. Also in this trial, 15% of these aspergilli were non-fumigatous cryptic species, which could be perhaps less susceptible to amphotericin B. And that might in part explain the lesser efficacy of amphotericin B. Also remember, this was an old trial. No biomarkers were available for early diagnosis or early initiation of treatment. Neither was therapeutic drug monitoring for voriconazole used in this particular trial, and these two factors could have certainly altered the results. But this has certainly remained the drug of choice. Recategorization of episodes of these from that trial have also confirmed that voriconazole has a superior efficacy. Over the years, other trials have emerged. So we have one trial from Dr. Chandrasekhar's group. So this is non-inferiority of neoazoles to voriconazole was shown in an externally controlled trial, and therefore we might actually consider the neoazoles as contemporary choices instead of voriconazole. So we have this trial from on isavuconazole from Jan Martens and on posaconazole again by Martens. So that really brings the very prominently the role of the neoazoles. Why not echinocandins? They are certainly not sidal for aspergillus. They do show some efficacy in salvage. But here in this patient, we also note that it has no ocular or CNS penetration. Now, surgery in this case was offered as a diagnostic as well as therapeutic procedure. Remember, this was 2011. No galactomannan or PCR for aspergillus was available at this time. So there was really no way to make a diagnosis of aspergillus being the cause of this endocarditis. At surgery, large vegetations were found, a papillary muscle abscess was found, vegetations were growing along the left ventricular free wall, a mitral valve replacement was done, and we did maintain a high dose voriconazole in this patient, perhaps to compensate for the induction effect of rifampin, which this patient was receiving. And we also added anidulafungin to this particular, in this particular patient. Like I said, it doesn't have a sidal effect, but there was limited data from Karen Ma's group in 2004, where this was used in a handful of cases in the salvage setting, where adding an anidulafungin was beneficial in a handful of cases. Taking a cue from this, because we had this difficult infection and difficult clinical situation, we used anidulafungin. Now, this same group has published this study, which also is a rather small study, in which they added anidulafungin to voriconazole, and that resulted in a trend towards improved survival. And this was in hematologic malignancy population patients with invasive pulmonary aspergillosis. And it was statistically significant improvement in survival in those patients who had a biomarker-aided diagnosis. In other words, these were early cases which they could have a better result with the use of these two drugs. Now, extrapolating from this study, of course, this is back in time because this patient was treated much earlier in 2011. Combination treatment could be justified. Now, this patient was unlike the patients in this trial. This patient was not hematologic malignancy. This patient had late rather than early disease, but the patient had endocarditis, was expected to have very low levels of voriconazole due to rifampicin, and was at a higher risk of adverse outcome. So although there is very limited data on combination therapy, it could be utilized in a case with difficult prevailing circumstances, as in this patient. Now, why choose anidulafungin and not caspo or micafungin? Possibly there is less interaction. There is in fact no interaction with rifampin, and no dose alteration is recommended, as is recommended with caspofungin. Unfortunately, after initial improvement, there was deterioration in the CNS status of this patient due to hemorrhagic transformation of the cerebral lesions. Now, this was the reason for a deterioration rather than uncontrolled primary disease, but the relatives decided to limit further treatment. So the messages which come out from this case is Aspergillus endocarditis is certainly a very difficult diagnosis, as blood cultures are almost always negative. For example, if you see a patient who's got appropriate host factors, who's got large vegetations, but cultures are continuously negative, it can't be Candida, so it should be one of these molds, especially Aspergillosis, because others such as Fusarium and all may be showing positivity in blood culture. Now, serum galactomannan and PCR actually would be invaluable in diagnosis in this particular situation. Obviously, they were not available at that time. Now, TB is so ingrained in the mind of most physicians in India and maybe in some tropical countries that empiric anti-TB treatment is often started and is continued despite evidence of no TB or despite evidence of an alternative diagnosis. Now, is that harmful? Certainly it is, because rifampin interactions can be very troublesome for efficient azole therapy. Now, surgery for suspected aspergillosis endocarditis can be both diagnostic and therapeutic, although now we may have a biomarker-aided diagnosis. But the problem is about timing of surgery after CNS emboli. It is still a difficult issue due to the risk of hemorrhagic transformation of the cerebral lesions, as happened in this particular case. So I'll close, friends, by saying that mold infections do pose distinct problems in diagnosis. Now, biomarkers and PCRs are now used, and you might even have breath tests based on metabolomics for diagnosis of, say, maybe pulmonary or sinus mucormycosis. Culture, species ID, antifungal susceptibility tests are all needed, and maybe establishment of clinical breakpoints are also needed. It's, of course, a work in progress, but maybe one day we will get there. In the meantime, therapeutic drug monitoring and trying to achieve PK/PD exposures, the highest possible PK/PD exposures in all these difficult situations, are very helpful. I can't tell you how important is the role of surgery. It's pivotal in both the cases that I talked about, and it can be significant in some others. But at the same time, there's a potential for cure if we diagnose these patients early, accurately, and treat them appropriately. And all these factors make the management of these diseases both challenging as well as rewarding. And both these cases showed you that unless every small bit of the part of management is done perfectly, the outcome is really not going to be what we would desire. With this, I'll stop my screen share. We'll be happy to take some questions. And I'm sorry for the poor connection. Over to you, Madhu.
Thank you so much, sir, for taking us through such a difficult case and guiding us about your challenges in diagnosis and treatment options. With probably interest of time, we'll move on to the panel discussion, but I request you to stay with us till the end of the session so we could take more questions. So I would like to introduce our moderator who joins us from Sri Lanka today, Dr. Suranga Manilgama. He's the president of Sri Lanka College of Internal Medicine and consultant physician at National Institute of Infectious Diseases, Sri Lanka. Welcome, sir.
Good evening, everyone, and thank you, Madhumita, for your introduction, kind words of introduction. So we'll move on to the second part of the discussion today. So this will be a case discussion. So we have 5 panelists. I will introduce 3. The Dr. Namal Jayawardena, She's a consultant mycologist working at Apeksha Hospital, Sri Lanka. The second panelist is Dr. Vimalasiri Uluwathage. He's a convener to Infectious Disease Forum, Sri Lanka College of Physicians, and he's a consultant physician working at Teaching Hospital, Karapiti. It's National Hospital, Karapiti, Sri Lanka. The third panelist is Dr. Nilanka Pereira. She's a senior lecturer and consultant physician, Department of Medicine, University of Sri Jayawardenepura, Sri Lanka. So, Madhumita, can you introduce two of the panelists from India?
Sure, sir. Dr. Kirti Sabnis, who's an infectious diseases consultant at Fortis Hospital, Mulund in Mumbai, and Dr. Lakshman Jesani, consultant infectious diseases physician and infection control specialist at Apollo Hospitals, Navi Mumbai. We'll have two case presentations in the panel discussion today. And the first case will be presented by Dr. Amila Ratnapala, who is a consultant respiratory physician from TH Karapitiya, Sri Lanka. Sorry if I spelled it wrong.
Thank you so much. That's all right. Thank you so much. And now they have upgraded to National Hospital Goal anyway. First of all, it's a pleasure to talk to you today. And can you hear me?
Yes,
Yes.
yes.
Yeah. So I'll be sharing my slides now. Can you see my slides?
Yes.
Yeah. So my patient is a 34-year-old previously healthy mother of one child admitted to the local hospital 3 months back with fever, shortness of breath, and cough for about 1 week duration. She has been managed as severe community-acquired pneumonia with newly diagnosed diabetes mellitus. And however, I mean, she was managed appropriately. She readmitted with similar symptoms after 1 week from discharge, and then admitted to the teaching hospital Karapiti with progressive symptoms. She was hypoxic at the time of admission to the teaching hospital Karapiti, and then we managed as severe pneumonia jointly with Dr. Vimalasiri Uluwathage. And as sputum studies repeatedly showed significant growth of coliform species, and we treated her appropriately with sensitivity pattern of antibiotics. And I'd like to discuss the X-rays of her. And even though that she's clinically progressing with worsening hypoxia and increased oxygen requirement, as chest X-ray changes remain static. For example, these are the initial 2 X-rays, so the X-rays at the local hospital. As you can see, there is left hilar consolidation, and there's a right middle lobe consolidation, which remains the same at the X-rays. That is our clinical challenge. Even though she's deteriorating, the chest X-ray features remain the same. Then actually, I'd like to invite Dr. Vimalasiri to discuss what we thought of, and then I'll discuss rest of the investigations.
Yes, thank you, Amila. Actually, at this moment, our challenge was now this patient presented to us as a relatively young patient who has been recently diagnosed with diabetes. Actually, during last presentation to the local hospital, they have detected her to be diabetic. And she, after two weeks of antibiotic, she was coming with severe respiratory symptoms as well as hypoxia. And initial investigation suggests even the blood culture and sputum became positive for coliform. So we treated as a severe community-acquired pneumonia with appropriate antibiotics. And now we manage this patient as a case of poorly resolving pneumonia in the background of newly diagnosed diabetes. But after a week after antibiotic treatment, actually we didn't see any much of improvement, and she became more and more symptomatic, and she became more and more hypoxic. And at that moment, actually we were thinking some other possibilities as well, and especially some of the rarer or atypical infective process in the background of immunocompromised state. So things like pulmonary tuberculosis was top on the list, as you all know that we are very endemic country. And apart from that, viral infections such as cytomegalovirus and HIV associated infection like PJP, or whether this is an invasive fungal infection, even though we are not familiar with that kind of presentation. And lastly, non-tuberculous sort of mycobacterial infection was also considered. So that as far as the infections are concerned, but we had some other possibilities in mind also, whether this is going to be a secondary organizing pneumonia, secondary to COVID infection or any other bacterial pneumonia. And third and last possibility, even though it's rare, being a female, we were thinking of the possibility of autoimmune type of pneumonia. Second, leading to some kind of interstitial sort of lung disease, making her more and more hypoxic. So those are the possibilities that actually we were thinking of. And to explore some of these things, some of these possibilities, we order some of the investigation. I think we can go through the investigations. Amelia, you can show the list of investigations that we have done.
Yeah, so we have done culture. The sputum culture has grown coliform species throughout with a similar sensitivity pattern. The blood cultures and urine cultures are negative throughout. And we did the tuberculosis workup, and the sputum studies were negative for acid-fast bacilli, and we did amount to there's no induration. The sputum gene expert as well as the bronchial lavage gene expert later became negative. So TB investigations were negative. And we did influenza A and B, RT-PCR, COVID-PCR, HIV-1 and HIV-2 antigen antibodies. They're all negative. We did the melioidosis antibodies as well. And we do have this sputum for PJP, which is a quite less sensitive method, but anyway, it was all negative. At
this moment, actually, can I interfere, Amelia?
Yeah, definitely.
Now, at this moment, actually, now the patient condition was not improving, and the best investigation of choice we thought was bronchoalveolar lavage, but she was quite oxygen dependent. She was heavily oxygen dependent, and we could not proceed with that procedure. And the next choice was for us to order HRCT. And shall we go through the HRCT finding?
Yeah, so we did HRCT. I'll run through the HRCT. These are the lung windows of HRCT. And as you can see, when you're going lower down, in the right upper lobe, there's a large area of ground glass opacity, as well as there are multifocal ground glass opacities. And if you focus on the left main buccal, you may see that it is narrowed with a possible endobronchial material. And there's a possible area of single cavity. I'm not very sure whether it's a single dilated bronchi, and there are multifocal areas of consolidation. So this is the time, actually, we didn't have much time to wait, and she's not fit for any invasive investigation because she's heavily hypoxic and she's on a large amount of oxygen. And then we decided, based on this CT appearance, particularly, even though there's no pathognomonic features of invasive fungal infection, this large ground glass opacity we saw in the right upper lobe, as well as multifocal areas of ground glass opacities, as well as these multifocal consolidations we saw in the left lower lobe, and the possible necrotic material we saw in the left main bronchus in the CT scan, as you can see here. So we thought that it could be invasive fungal infection because she is a newly diagnosed patient with diabetes and exposed to a prolonged course of antibiotics. And she's coming from a farming background. So with all these clinical host criteria as well as regulatory criteria, and we decided to start her on treatment with IV voriconazole empirically. And with this treatment, actually, she remarkably improved, and she became completely oxygen independent within a week of treatment. However, we didn't have any confirmatory investigation, so we decided to proceed with the bronchoscopy as she's free of oxygen. So the bronchoscopy, we found this left main bronchus. You can see in the screen that there are areas of necrosis, soft necrotic material, which are completely occluding the main bronchus. And we took some samples of it, and we sent for the investigations, as you can see. So the fungal culture, they have not seen any hype there, and the pyogenic culture again show heavy growth of coliform. even though we were appropriately treating. And the BAL for TB culture was actually, now it is negative, but at the time we didn't have any results. And the galactomannan became heavily positive of 1.19, and the AFP-DXB as well as the BAL for TB PCR became negative. So this patient was successfully treated, and with this definitive treatment, we have given 14 days of meropenem as well as cotrimoxazole with the sensitivity pattern, and then we gave IV voriconazole for about 2 weeks duration, and then stepped down to oral voriconazole, and she's still on oral voriconazole for about 6 to 8 weeks, and we're planning to do the repeat CT scan end of this month, and repeat bronchoscopy, see if there are any other necrotic material, and see whether she's radiologically as well as bronchoscopically improving.
So if
So
I
this
could
is
ask
yeah.
a couple
Yeah.
of our panelists, the Indian panelists. So if you could go back to your CT images.
HRCT.
Yeah,
Okay,
there you go.
looking at this CT image, Dr. Kirti, what would you do in India?
So the first is syndromic diagnosis. So she is a newly diagnosed diabetic with not improving on the therapy. So definitely, I will like to have serum markers, because if we are not able to get the BAL samples done, definitely serum markers for beta-D-glucan and galactomannan will be the first thing. There is quite a bit of ground gassing, and she's from the community. We have seen a lot of community acquired aspergillus following a viral infection. So whether she had anything before, like a respiratory flu or a COVID to start with, and then it followed aspergillus, I'll be more interested. So if she time duration fits in within first week of onset of the symptoms, I would like to have a viral markers also to know why she had a aspergillus. Only diabetes is not a common risk factor to have a fungal invasion, because the neutrophil defect which we see in hematopoietic patients or post-transplant patients is not seen as prominent as in diabetics. So whether it is like a community acquired aspergillus with starting as a viral, I like to be more interested in.
Thank you.
Yeah, the clinical syndrome, the more clinical syndrome is like, first hit most likely from a viral infection, even though that we did the viral antigen at the teaching hospital Karabit, because most of the facilities are not available in the local hospital. She came to the teaching hospital Karabit here about 3 weeks later. So therefore, I think it looks like she might have a viral prodrome at the beginning of the disease. And even though that we could not confirm at the time of admission to the local hospital.
Amila,
yeah.
Yes. Now looking at the HRCT, so what are the features for and against viral infection, the fungal infection? So you at the beginning you had a lot of differential diagnoses started with, then to confirm or the suspect viral infection, the fungal infection, what are the features?
Basically our working team was actually a non-resolving pneumonia in a potentially immunosuppressed host here. So in this HRCT, we didn't see the more classical features of halo as well as reverse halo sign, which is more towards more fungal infections as well as some diffuse nodularity and all. But in this CT scan, this unilateral ground glass densities, which was the main reason that we thought that it could be a fungal infection rather than viral infection. In viral atypical viral infection, we see more generalized pneumonitis type of picture involving both lungs, and but here it is more likely that there's a focal areas of ground glass opacities. And the other reason is this possible necrotic material, possible occlusion of this left main bronchus by this necrotic material. Even you can see in the CT scan here that the left main bronchus is narrowed with potential necrotic material. These are the main factors we thought of invasive fungal infection, particularly invasive aspergillosis here.
Yes. Can we go on to the 11th slide? The slide after this. Okay, so over here, we didn't have a microbiological evidence apart from just a BAL galactomannan positive. We did not grow a fungus in the cultures. Dr. Lakshman, would you like to throw a light on this BAL galactomannan values?
Yeah. So as you had presented this case, a young patient, diabetic patient presenting with a non-resolving pneumonia who has a cavitatory lesion in the lungs. Two things we have to not miss out. One is the bacterial infection like Burkholderia. Melioidosis is always possible in this particular case. I'm sure you had sent all the required cultures. Second thing is we should not miss a diabetic patient with this cavitatory lesion is mucormycosis. In fact, pulmonary mucormycosis is known to occur in this diabetic patient. In fact, we recently had published a paper of a case series of pulmonary mucormycosis in diabetic patients and who did not present acutely. They presented with respiratory symptoms for a couple of weeks to months and then diagnosed to have mucormycosis. So definitely my differential diagnosis would be mucor versus aspergillus in this particular case. Now, like Dr. Kirti mentioned, we could have sent the galactomannan and beta-D-glucan. So beta-D-glucan definitely would have been a useful test to diagnose the aspergillus, but again, beta-D-glucan would not come positive for mucor. But for galactomannan, the galactomannan is useful, especially if you have a hemonc setting patients who are having hematopoietic stem cell transplant patients or oncology patients. In that, the galactomannan can be very significant. How significant is galactomannan in an immunocompetent patient is not that great. So maybe serum galactomannan would not have been that useful, but having a BAL galactomannan positive value of more than 1, we can consider as significant, but we know that there are certain false positives of galactomannan as well. For example, if the patient has been on piperacillin, tazobactam, antibiotics, or the way the galactomannan was not sent in a proper culture medium. So those are the results in which the galactomannan can be false positive. So instead of a single value of galactomannan, I would prefer to have a serial value of galactomannan. As you rightly put up in your case, you're planning to do bronchoscopy again. We would definitely like to see a repeat galactomannan of this patient. So you are right in treating with voriconazole for invasive aspergillosis, but mucor is something that we should not rule out and keep at the back of our mind, because we also know there are few cases in which aspergillus and mucor are known to coexist together. There is called as mixed infections which are there. And my only concern is that we don't have a microbiologically proven invasive fungal infection in this particular case. So those are my thoughts.
Yeah.
Yes,
Can I
just
ask?
to-
Can I ask Namal? Namal, can you tell us more about the diagnostics as well as the treatment of aspergillosis in this setup? Namal?
Yeah, thank you, Dr. Suranga. So in this patient, as some of the panelists said, like if you take the host response, the patient is not overtly immune suppressed. The patient is not really at risk of invasive pulmonary aspergillosis. And however, the CT findings, as someone said, I mean, you do have a patch of ground glass. Yes, I agree. But I mean, it could have been a resolving viral infection with the superimposed secondary bacterial pneumonia is also possible. And coming to the BAL galactomannan, for BAL, the cutoff is actually 1. So it's a kind of a very low positive. And the fact that there was no hyphae seen in the direct smear and the culture did not yield any fungi is kind of goes against the diagnosis of invasive pulmonary aspergillosis. However, as Dr. Amila said, there was a necrotic material when he did a bronchoscopy, so I have no doubt it may have been colonized. I think one of the panelists was talking about mucormycosis, but correct me if I'm wrong, but in uncontrolled diabetes, it's mostly it's more for rhinocerebral aspergillosis, rhinocerebral mucormycosis that happens rather than a pulmonary mucormycosis. So yeah, it goes both ways. So I mean, this is I'm not overtly convinced that this could be invasive pulmonary aspergillosis, but I mean, clinically the patient did respond. So that's also for treating this patient as a pulmonary aspergillosis. And as someone said, I think it would have been good idea to repeat the bal-galactomannan and see if there is actually a response, if the titer is going to fall following treatment. Yeah. So thank
And
you.
again, regarding the treatment, the voriconazole treatment, within 1 week, patient was recovered. So the patient was responding. So is it common to respond in
Actually,
1
yeah,
week?
because yeah. So one thing is we should tell our Indian panelists we don't actually have therapeutic drug monitoring in our country. So we don't do it. It would have been very, very useful if we did have it. Usually, voriconazole takes about 5 days to achieve therapeutic drug levels. So having this much of a dramatic response when the tachypnea and whatever else the symptoms that the patient has, if, within 1 week for it to be dramatically responded, I'm not too sure about it. Yeah, but however, obviously, maybe repeating the BAL and seeing what happened to the necrotic material and the bal-galactomannan, maybe if we could follow up the patient and see, it would give us more information. Yes.
I'm going to take liberty to ask our previous speaker, Dr. Rajiv Soman. So this question was asked to you. Is it possible to differentiate mucor and aspergillus by radiology? So an image like this that we had in this case.
Yeah, there are some classical features which distinguish these two molds when it comes to pulmonary involvement, but they are not sort of sacrosanct. Okay, so if finding more than 10 nodules, prominent reverse halo sign, cavitation, involvement of the pleura, involvement of
Okay, probably when he connects back, we get on to that question again. Dr. Lakshman, how specific is serum galactomannan in diagnosis of pulmonary aspergillosis in a patients who are too unstable to go through bronchoscopy?
Yeah, so it depends on the type of host. So if it is an immunocompromised host like a Mehi-Monk patient, patient on chemotherapy or stem cell transplant patient, in those patients, serum galactomannan values, a serial rising values is quite specific for aspergillosis. But I said it is not only for aspergillosis, there can be other false positives which can be present as well. So the better way is to do a bal-galactomannan, which has much more superiority over serum galactomannan, and serial bal-galactomannan values are much more significant other than a single value. So bal-galactomannan of more than 1 to 1.5, that would be considered significant. So given this patient, you have started voriconazole, patient has shown response, definitely we would think aspergillosis is possible in this case, but I'd like to keep a close follow-up so that we don't miss anything further in this particular case.
Thank you.
with my connection today. I'm sorry.
Yes,
I don't know why
no
there are
problem.
so but anyway, I talked about a few radiological signs, but again, I will tell you that something developing while the patient is on voriconazole, patient having very uncontrolled diabetes, ketoacidosis. These would be findings which that is never completely sacrosanct. So you do need
Thank you, sir.
biomarker to help you, and of course, maybe.
For the interest of time, shall we move on to the second case?
Sure.
Yeah, may I introduce the second case? The presenter is Dr. Dumita Govindapala. She's a senior lecturer and consultant physician working at Department of University of Jawadhanapura, Sri Lanka. So she will be presenting the second case. Over to you, Dumita.
Thank you, Suranga. Good evening, everyone. I think you all can see my screen.
Yes, we can. Yeah.
Yes. So this second case presentation is on a patient with recurrent candidiasis who had undergone a very complex abdominal surgery. Because this patient was mostly managed by our surgical colleagues. And this is a 58-year-old female who was previously healthy. And her initial presentation to the hospital was in August 2023 with a left-sided lower abdominal pain and early satiety for 6 months. She was extensively investigated and a diagnosis of locally advanced pancreatic ductal adenocarcinoma was made in September 2023. Then she was referred for neoadjuvant chemotherapy. She completed 7 cycles without any major complications. Then she underwent an extensive abdominal surgery where an en bloc distal pancreatectomy, splenectomy, left nephrectomy, and resection of cup of stomach and diaphragm, and reconstructive gastrojejunostomy and polycolic anastomosis was performed. Immediately after surgery, the patient was admitted to the ICU for monitoring, and her immediate postoperative period was uneventful. So the patient was stepped down to the HDU on the postoperative day 3. However, following the next few weeks, she developed several surgical complications. She had an intra-abdominal fluid collection requiring a guided pigtail insertion for drainage, and an anastomotic leak was suspected at that point. And she was started on broad-spectrum antibiotics because she started spiking fever on postoperative day 5 onwards. And during these 4 weeks, most of the days she was kept meal by mouth. Thus, her nutrition requirements were met with TPN. So this slide summarizes her basic investigations during the first 4 weeks. As you all can see, apart from a positive urine culture for Candida during the second week, all her microbial cultures were negative during this period. So in the sixth week postoperatively, her both urine and blood cultures became positive for Candida. And as in the local hospital, the fungal typing and sensitivity testing was not available, she was empirically started on fluconazole, and her samples were sent to the Medical Research Institute for further evaluation. The typing revealed a growth of Candida glabrata in her blood, which was found to be resistant to fluconazole. However, by the time this report became available, the patient had responded clinically. Therefore, it was decided to continue with fluconazole. And in the 7th postoperative week, patient became septic. And she was again admitted to the ICU and treated for a hospital-acquired pneumonia with broad-spectrum antibiotics. And her condition further complicated with the pancreatic fistula and gastroparesis. She was treated in the ICU for 5 days and again stepped down to the HDU. And during this period, she was closely monitored, and her microbial cultures were repeated at a regular interval. In the 10th week, again, her central and peripheral blood cultures became positive for Clavispora lusitani, which was sensitive to fluconazole. However, at the time of initial diagnosis, because the typing and the antifungal sensitivity testing was not reports were not available, she was empirically started on intravenous anidula fungi and then continued for 14 days. The following week, patient suffered a respiratory arrest, again admitted to the ICU, and she was intubated and ventilated for 3 days, and she remained in the ICU for following 3 weeks. During this period, again, her CVP tip culture became positive for Candida, but at this time, because her peripheral blood did not reveal any growth of fungal infection, she was not treated, thinking that it could be a colonization. In the 14th week, again, the central blood culture became positive for Candida. parapsilosis, and she was treated with fluconazole for another 14 days. So this was a very complicated history, and patient actually stayed in the hospital for nearly 5 months, and she recovered, and we managed to discharge her last week. So this slide summarizes all her microbial positive culture reports. And at this point, I'm going to stop and ask Suranga to discuss this case with the panelists. Over to you, Suranga.
Thank you, Dumita. So we have discussed a patient who has undergone major surgery with a prolonged hospital stay, and patient has had chemotherapy at the outset, then multiple courses of empiric antibiotics. So, when we are listening to the case, we heard that patient has had 3 infections. The first with Labrador, then Clavispora, then after that Candida infection with another species. So I would ask, I would like to ask why patient has had 3 different species, the Candida infection with the fungal infection with 3 different species, and is there any reason, and why this patient is more prone to get fungal infections? I would ask that from Nilanka. Nilanka, are you around?
Yes, Miranda. So I think I'll just highlight why this patient is likely to develop Candida infections. It's quite obvious because we know Candida is a commensal in the gut and the skin. So this patient underwent one thing is the major GI surgery. So her gut barrier was disrupted, and then she was also prior to surgery also she was anyway immunosuppressed because she had neoadjuvant chemotherapy as well. And then the major other problem is, Candida forms biofilms in any prosthetic material. So she was on several central lines inserted initially for chemotherapy, and then following that she was also on central venous lines because of the fact that she required total parenteral nutrition. With all these things, she was actually quite likely to develop Candida infection. And also the other most important factor would be the fact that she had prolonged courses of broad spectrum antibiotics. So from there, of course, that could be everything kind of predisposed her to get Candida infection. And the fact why she got different types. So I think I would just switch to Namal to just comment about these different types of Candida infection she got.
Namal?
Yeah, thanks, Nilanka. So this is a very, very complicated patient who has had major abdominal surgery and who has been in the hospital, as Dr. Dumita said, for a long time. So she has several risk factors, as Nilanka said. So I would say the main reason she would have several episodes of candidemia may have been her disruption to her mucosal barrier because of her major abdominal surgery. So I think she has had several leakages, and so the mucosal integrity was disrupted for quite a long time. So maybe initially she was azole naive. She was not given any antifungals. So it's a bit odd that she has developed a resistant Candida glabrata is known to be fluconazole resistant. So it's a bit odd that she has her initial candidemia is due to a resistant bug. But then, however, later on with her treatment, antifungal treatment, she and her continuous disruption to her mucosal integrity, she has developed a Candida lusitaniae or Clavispora lusitaniae, as we call it now. And Clavispora lusitaniae is usually can be resistant to amphotericin B. So that would explain why, and the patient has previously been on azoles, so that would explain why the microbiologist decided to go with anitulofungin. And then later on, with her continued use of plastering of her central lines, she may have developed Candida parapsilosis, which is usually associated with the plastic and development of biofilms. So a lot of, as you can see, a lot of factors come into play. And with her continued stay in ICUs, broad spectrum antibiotics, use of parenteral nutrition, all of it have come into play and caused these 3 episodes of candidemia. And also, I suppose I can just mention about the Candida urine culture. So it's obvious that she's been colonized with Candida as well. So that also may have, it would have been interesting if we were able to know, which we don't usually speciate the urine candidas, but it just shows that she's been colonized with Candida as well. So yeah.
Yeah.
Can I ask Dr. Lakshman, what would you do when you see a Candida glabrata growing?
Yeah. So this case is a typical case of a high risk case of candidiasis, because if we apply the Candida score, she had a GI surgery, she had central line, she had multifocal colonization with Candida. Possibly she also must have been in TPN when she had this pancreatic removal which was done. So typically she's a high risk for Candida. The only thing is there are 2 sources of Candida in this patient. One may be the gut translocation because of the extensive amount of gut surgery she has done. And second could be a nosocomial cause of Candida, which may be because of central line related, which she had the central line for quite some time. It is indeed intriguing to see why a patient would have 3 different species of Candida at 3 different intervals of time. Possibly she must be having a mixed species and one got selected out of the other. So when the first report comes of Candida glabrata, now Candida glabrata is known to have high MICs for fluconazole. In some cases, they are totally resistant to fluconazole. In any which way, if the fluconazole can still be given in glabrata, if we give a high dose fluconazole. So a high dose fluconazole would be something like 800 to 1200 milligrams per day. But given this case, the patient had a resistance to fluconazole. Instead, I would have preferred to start with an echinocandins, preferably an anidulafungin at the right doses. And it has to be given for 14 days from the last negative blood culture. So I would have started the patient on anidulafungin once the Candida glabrata is there. Repeat blood cultures every 48 hours. Once the 48 hours blood cultures are negative, from there count 14 days. Second thing, one more reason why the Candida species could be persistent in this patient is basically there could be a disseminated candidiasis. By that I mean the patient's Candida could have been seeded in other organs. For example, like hepatic, spleen, or even the eyes. So that is why after starting echinocandins for this patient, after 1 week, we need to do a fundoscopy to see whether there is any ophthalmic seeding of Candida is present or not. Maybe get a CT scan of the abdomen to see whether there is any hepatosplenic candidiasis or not. So that would be my thing. But it's really interesting why 3 different species have grown. Maybe because the fluconazole was resistant, it got selected out and then the other species grew further. But the treatment of choice in my case would be anidulafungin, 14 days from the last negative blood culture.
Yeah, can I ask one more question from Dr. Lakshman? So you said patient is looking at the patient's characteristic patient is at high risk for Candida infection. So we know that the second week also patient developed positive urine for Candida. So would you use any treatment at that time?
So Candida, yes. Absolutely. So Candida in urine is probably a colonizer. There is Candida rarely causes any urine infection or any pyelonephritis in very rare cases. So presence of Candida in urine in a asymptomatic host need not be treated. But this patient has Candida risk factors. She had a GI surgery, TPN, lines, and then she is colonized with Candida. So that is the reason I would suspect it to having an invasive candidiasis. But a urine Candida coming positive in an asymptomatic patient, even in a diabetic patient, we usually don't treat it. It should be left untreated.
Okay.
And Dr. Lakshman, I have a question for you. Now, as you said, the second time when her Candida, when her blood became positive for clavispora, she was given anidulafungin actually because we didn't have the sensitivity pattern by the time we got the Candida positivity. So considering the previous report, we gave her anidulafungin. And as you said, after the last positive culture, we continued it for 14 days. But again, in the 14th week, she developed Candida infection again. How do you explain that?
Yeah. So the last candida is Candida parapsilosis, and Dr. Namal said parapsilosis has a specific affinity to plastics. So I think the third candida which she has got is definitely probably central line associated, because this parapsilosis forms a biofilm along the central line. So that is the reason. And if you notice, Candida parapsilosis has high MICs for echinocandins. In fact, many a times when we get Candida parapsilosis, the treatment is always remove the line, and maybe you can spare the echinocandins because they have high MICs, or give echinocandins at higher doses. So the third candida I feel is line related, and echinocandins have high MICs for parapsilosis. That is why probably the echinocandins didn't work in this case, and she came culture positive.
So may I ask Namal, so what are the fungal identification sensitivity testing available in Sri Lanka, and so can you brief on that?
Yeah, so Suranga, so in our country, usually at the peripheries, we don't have routinely we don't have identification sensitivity testing. So the samples are usually sent to the reference lab at the Medical Research Institute for identification and sensitivity testing. So that would explain why in this case some time was taken before the identifications were available. But however, we do have some automated methods in certain select hospitals. But I have, we do have Vitech system, we do have the API system in certain selected hospitals, the Phoenix system. But I do have to say that the identification is not, there are problems. It could be identified with these different systems, and the VST, also the antifungal sensitivities, could also be incorrect sometimes. In this case, they did not have it, but however, they went by the clinical judgment and the patient has responded. So that's why they have stuck to fluconazole, for example, in the first isolate. So yeah, in Sri Lanka, we don't have Molotov in our country as yet. So it's usually done by manual methods at the reference lab, or in, as I said, certain automated methods in certain hospitals.
Okay. And any reason for secondary prophylaxis in this patient? I would ask Dr. Lakshman.
Yes. So to begin with, because this patient has an extensive surgery and high risk for candidiasis, you probably could have started the patient on fluconazole prophylaxis. She is a candidate for fluconazole prophylaxis, considering the extent of intra-abdominal surgery which she has undergone. But anyways, probably that would not have worked because she had selected out for Candida glabrata, which is anyways resistant to fluconazole.
So what is the dose of fluconazole if we are going for prophylaxis?
Yeah, so prophylaxis, the dose would be around 600 to 800 milligrams, depending on the weight of around 60 to 70 kg per persons per day. Yeah.
Okay.
I'm going to ask Dr. Chandra what he would do if he sees a patient like this.
Yeah, real quickly, thanks, Madhu. I have to kind of disagree with some of the comments I heard. This is a patient who has an intra-abdominal problem. You can see week 13, patient has enterococcus in the blood. And week 7, there is coliforms in the blood. Where the hell are these coming from? They're coming from the belly. With all the surgeries, patient has extensive distal pancreatectomy and GI surgery. So we have to have source control. So you have to look at the CT scan of the belly, make sure there is no pancreatic abscess. And that has to be the primary focus here, rather than saying patient has recurrent candidiasis and therefore I need to give prophylaxis. I don't think that is the right approach. I think controlling the belly problem is the fundamental issue, and that is far more important than giving antibacterials or antifungals in this patient. Unless source control is accomplished, obviously there is a problem with the mucosal disruption contributing to these issues. Whether there is a focus of collection, an abscess, that can be dealt with through imaging and careful physical exam. I think that should be a very important focus. Obviously, the fact that there is parapsilosis, Lusitaniae, and glabrata, these are all GI organisms. They're coming from the GI tract, and it's less likely to be of cutaneous origin. So here the fundamental problem is recurrent intra-abdominal pathology that has not been dealt with adequately, either the cancer itself or post-surgical complication.
So many a times we've noticed that, a first sign of a GI mucor is all these fancy organisms growing in the blood. You don't explain why these patients have recurrent polymicrobial bloodstream infections. So with that, I mean, you need to screen, you need radiology, or sometimes it's visual inspection. You open the abdomen and see for ulcers and perforations. There is one question from one of our viewers is there a biomarker for mucormycosis, and why is it not available?
Yeah, that's $1 million question. There is no biomarker reliable, commercially available. It's not available. There are home brewed PCRs, but it's not widely available. Why it is not the case? There has been a lot of investigation. There's been quite a lot of publication, but it's still, we do not have a standardized, validated molecular tool. Why? I don't know the answer. Obviously, these are difficult issues, difficult to come up with an appropriate molecular assay. So it is difficult at this time. Even for Aspergillus, we've been struggling now for 3 decades. And if we have PCRs, a lot of them, the tests are not validated. So mucor today, we still continue to rely on basic culture and histology.
So there's another pressing question which everyone asks. We have many complicated hepatobiliary surgeries, but our policy is not to give prophylaxis, not to treat urine, and not to treat sputum candida. Is this policy because we have very limited antifungal for therapy? And in a catheterized patient, how we decide on treating urine candida? So on one side, you tell, don't treat the urine candida or don't treat the sputum because they're all colonizers. When would you actually treat?
Okay, let's take the sputum candida. As you know, many times in the ICU, medical ICU or surgical ICU, in intubated patients, when you take the endotracheal specimen, usually there could be candida along with a bunch of bacterial organisms as well. The interpretation is the patient have respiratory candidiasis. The answer is no. The patients have colonization very frequently with the intubation itself or with antimicrobial exposure or stay in the ICU. In general, the teaching is candida does not invade the lower respiratory tract. Candida does not know how to break the bronchial barrier and get into the lung parenchyma. It doesn't happen. Pulmonary candidiasis is a relatively rare entity. So if you have candida in the bronchoalveolar lavage or in the endotracheal specimen, it should by and large be interpreted as colonization rather than true infection of either the upper respiratory tract or the lower respiratory tract. Very rarely you can see pulmonary candidiasis in patients who are highly immunocompromised. Advanced leukemic patients may have the candida leave the bronchial tree, get into the pulmonary parenchyma, and may cause lower respiratory tract disease. And that is usually seen at autopsy. So it's very rare for us to see a pulmonary candidiasis, except in highly immunocompromised patients, and the vast majority should be interpreted as simple colonization and not be treated. And as for the urinary tract, it's a slightly tricky. Once again, candiduria in the absence of symptoms does not have to be treated. If the patient does have symptomatic candiduria, the candida cystitis primarily, and that could be approached and that can be treated. And patients who have catheters, by and large, it simply represents colonization And removal of the catheter is the answer to get rid of the colonization, not drug therapy. Again, it's easier said than done. You can't remove the catheter. And if you're stuck with the catheter and the patient continues to have asymptomatic candiduria, that does not have to be treated. Once again, simply represents colonization. It's a long answer. Sorry I took so much time.
May I say something?
Sure, please
Yes.
go. You're working. Microphone is working now.
Yeah.
Yeah, please come.
Okay, asymptomatic candiduria, do not treat, but save a few clinical situations. So if you
Okay.
have preterm babies, if you have a neutropenic patient, or if you have a patient who is due to undergo a urologic procedure, these might be three indications where you might want to treat asymptomatic candiduria. Also, we must remember that sometimes this can be an example of a descending candiduria. So by that I mean the kidney is one of the organs which could be seeded during the course of candidemia. And if that happens, unlike the lung, the kidney can be definitely seeded very well by candidemia, in which case sometimes it might break open into the collecting system and you might find the bug in the urine, but that is not just asymptomatic colonization of the urinary tract, but it is actually representing upper urinary tract infection. So we have to keep these things in mind when we dismiss urinary candida, because in the vast majority it is a colonizer. Also, they have done strain concordance studies. That means the patients who have candida in the urine, and if the same patient happens to have candidemia, the strains do not have concordance. And the same thing is true for respiratory as well as candidemia or invasive candidemia or invasive candidiasis isolates. So in these two areas, we have to, in the respiratory tract, by and large, we know that it is exceedingly uncommon to get candida, as Dr. Chandra said. And in the urine, for asymptomatic, there are just three indications when we might want to treat them. Thanks.
Yeah, I agree. Those exceptions have to be remembered. I can tell you in my practice, leukemic patients with candiduria, I do not treat. Again, the data is very, very soft. One has to take the whole thing into consideration and then assess. I'm not saying ignore the candiduria, investigate the candiduria, and then make a careful decision whether to treat or not to treat. Pregnant women, you have to be careful, and young babies, especially premature babies, they have to be treated.
I got one more question actually from, I would like to ask from Dr. Chandra. So this type of patients who have been managed in ICU with long-term CVP lines, in case if their CVP tip and the central blood became positive for candida, but the peripheral blood shows no growth, would you consider treating them?
You mean the catheter drawn culture is positive and peripherally drawn culture is negative? And the patient is symptomatic, the patient is, let's say, febrile and ill, you know.
At the same time, positive bacterial cultures as well.
Yeah, it's tough. It's tough. Again, here the question is, should I remove the catheter? You know, is the catheter colonized or is the catheter infected with the candida, and do I have to remove the catheter? If the peripheral blood culture is negative, it's somewhat reassuring. You can buy time, you don't have to remove. However, if the catheter culture and the peripheral culture is positive, then you have to figure out the source. And the concern is the line the source? Do I have to remove the line? So that again requires careful clinical judgment, assessing other possible sources, such as the abdomen. You know, if all the other sources are ruled out, or if the organism happens to be parapsilosis, then you would say, you know, more than likely it's the line, I'm going to remove the line. And removing the line is not an easy decision. It costs money, it costs considerable morbidity, and you have to put another line in anyway in these patients. So if you think the line is the source and it's reasonably certain for you, then you would have to sacrifice the line.
Thank you.
I hope I answered the question. It's a little tricky. There's a lot of bedside judgment is involved.
Thank you.
Yeah, I have a question for Dr. Dumita. Can you just tell us what is the current status of the patient? Like, how is he still posted for surgery, and how is his clinical condition?
Actually, the patient, we managed to discharge the patient last week. Actually, as Dr. Chandra said, it was mostly related to all the abdominal complications, probably because of the malignancy and the complex surgery. So she developed gastroparesis and pancreatic fistula, and also intra-abdominal collection, which was drained with the pigtail. But and then several cultures became positive, both pyogenic and fungal. So we treated according to the ABST patterns and sensitivity patterns, and given her all the nutritional support and other support. And we managed actually to send her home last week.
You said patient was in the hospital for 5 months?
Nearly 5 months.
Wow. You depleted his bank balance.
Actually, in Sri Lanka, the hospital care is for free. It's
That's
all
true.
free.
You depleted the government bank balance.
Yes.
Thank you very much. For the interest of the time, shall we conclude the case discussions? I would thank Dr. Namal, Dr. Vimalasiri, Dr. Nilanka, Dr. Kirti, and Dr. Lakshman for being panelists and wonderful panelists and discussing the 2 cases. And I thank Dr. Amila and Dumita for presenting very interesting cases. And also I would like to thank Dr. Chandra and Dr. Rajiv for giving their valuable input into the case discussions. And so we'll move to the next item. Over to you, Madhumita.
I think it's just the vote of thanks. I think we'll conclude the CME session. So I would like to extend a heartfelt thank you to all our esteemed speakers for that insightful presentation and valuable contribution. Special thanks to Dr. Chandra for joining us from US and Dr. Rajiv Soman for sharing his expertise on diagnostic and treatment challenges in invasive fungal infections. We are grateful to the case presenters for their active engagement and thought-provoking questions, and to our panelists for their involvement, which has truly made a very enriching experience this evening. And a final big thank you to the organizing committee, CIDS India and CCP, especially Dr. Nilanka Perara for bringing both the societies together and for making this CME a huge success. Thank you all for joining us today. I would like to extend a warm welcome to the CIDSCon, which is happening in India at Hyderabad from 16, 17, 18th August. And we would also love to share that CIDSCon has its own journal, and our very own Dr. Rajiv Soman is the editor. We invite a lot of original articles, case presentations for publications. So do submit your articles and cases for publication in CIDS journal. Thank you. Thank you for joining us.
Let me say something. I'm delighted to be part of the group. I'm so glad Vasant and the CIDS group brought the 2 countries together. And I hope this is not the only time. This is the first time. And let this be a roadway that we create for more collaborative work between the Indian physicians and the Sri Lankan physicians. And anything from the US side, I would be more than happy to serve as a bridge. And I hope to see many, many more such interactions. Thank you for involving me, Vasant. Bye-bye, guys. Bye-bye.
Thank you.
Thank you very much, ladies and gentlemen, and have a great day. And we'll hope that we'll have more fruitful and more interactions in future as well. That's great.
Thank you.
Thank you. Thank you. Thank you.